Hi, this is Brian Kim. I want to share with you case number 209 in the best way to do cataract surgery series. This is a moderately dense lens, and this patient also has weak zonules. And you're going to see how I place the capsular retention ring using the injector and hooking the leading eyelet so that it causes minimal torsional stress on the zonules. And then at the end, you're going to see the Hydrus microstent being placed. So I use a corneal marker, which will help me to center and size the rhexis, and I use a cotton tip to control the eye to do this. I'm turning the eye to the left so I can make my paracentesis incision first on the right side, and then this is the incision for the Hydrus microstent. I've decided to make those incisions ahead of time because in some cases you can get bleeding from the incision, and then you can get blood mixed with the viscoelastic that's on the cornea, which will obscure your view when you do the Hydrus procedure. This is intracameral epinephrine and then some dispersive viscoelastic to coat the corneal endothelium and flatten the anterior capsule. This is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, using the cannula to turn towards me, I'm able to enter. And this is the Moria micro forceps. They have sharp tips, so I can puncture the center, pull down towards me. And because it's sharp, it can behave like a cystotome and control your tear as you make it. Grabbing the right side of the tear, and then using the corneal mark that I made to help guide the size and centration of my rhexis. Because this forceps is really small, it causes limited OVD egress and therefore less radialization forces. Finish off the rhexis, burping some viscoelastic out. And this is the capsulorhexis hydrodissection technique. I'll place a cannula under the rhexis edge, contra-incisionally, point the tip down, get a nice wave, decompress the bag, sweeping and pushing BSS under the rhexis edge on the left side, and then hooking the peripheral lens on the right, and the lens begins to spin. Irrigating the surface of the eye, lifting the incision with a chopper, going in with irrigation off to minimize Descemet's trauma, removing the surface epinuclear material, placing the chopper under the rhexis edge, contra-incisionally, point the tip down, the phaco tip vertically sub-incisionally, fracturing the lens completely in half with opposing forces, that's double chop, placing the chopper around the right heminucleus, hooking the peripheral lens, crushing the lens against the phaco tip as if it's a chopping block, and that is the cross chop. Crushing the first quadrant in half, and then using mechanical fracturing forces to crush the lens into smaller pieces, and then emulsifying the lens pieces. Separating that second quadrant from the rest of the lens, placing the chopper around the lens, hooking the peripheral lens, crushing it against the phaco tip, using some vacuum to lift that piece up, crushing it into smaller pieces, and then emulsifying the lens piece. I don't know if you notice this, but as I'm removing the lens pieces, I can sense that there's a wobbliness to the capsular bag. It's just a feeling. You can see it too. It's just hard to verbalize, but as I'm doing it, I can feel that there's some wobbliness to the capsular bag. So turn that second heminucleus in front of me, placing the chopper around the lens, hooking the peripheral lens, crushing it, and that's the cross chop maneuver. Performing the same maneuver around the third quadrant, crushing the lens in half, using some vacuum to grab the piece, crushing the lens into smaller pieces, and then emulsifying the lens piece. Turning the fourth quadrant in front of me, placing the chopper around the lens, hooking the peripheral lens, crushing it against the phaco tip. Again, another cross chop maneuver, using mechanical forces to crush the lens into smaller and smaller pieces, and then emulsifying the lens piece. using some vacuum to grab that last piece, crushing it with the instruments, and then emulsifying the lens piece. Using some vacuum to remove the epinuclear material, keeping that chopper deep. So I take the chopper out, push BSS in, take the phaco tip out, and go in with the ironing handpiece. Always starting sub-incisionally. I'm peeling anterior to posterior. As I'm peeling, everything's going great. Remember, when you peel from anterior to posterior, you get a cleaner cleaning of the cortex and the capsular bag. Less likely to have those fine cortical wisps. Bag's nice and clean. Switching to polish mode, polishing underneath the rhexis edge. So again, during lens disassembly, I had a little bit of a sense that the bag was a little bit unstable. But now here, as I'm trying to polish the posterior capsule, look at how the posterior capsule puckers up into the port. And so that's why the polymer tip is so helpful. Not only to help cleaning the bag, but it helps you diagnose the fact that there's some weak zonules here. And so, a lot of people would just go ahead and put the lens in and not worry about it. And there'd be nothing wrong with that. But because I know that there's significant laxity of the capsular bag, the posterior capsule here, I'm going to go ahead and put a CTR. So I pulse BSS into the subincisional capsule fornix, turn irrigation off, and then push cohesive viscoelastic to fill the bag. Sweeping the anterior capsule underside of the lens epithelial cells, first on the left side and then the right side. And then we're going to go to the CTR. I always like to load these myself with the hook pointed down and orienting the leading eyelet parallel to the injector. I'm able to internalize the CTR into the injector. And I always like to keep it on that platform. You can see that vertical groove that was there. Hook the leading eyelet with the Lester. As I deliver the CTR, there's minimal torsional stress on the bag. Somehow I got snagged on the injector here. It's rather bizarre, so I had to lift it and then it went in. Yeah, it was just stuck on the lip of the injector. So I go in with a single piece acrylic lens into the capsular bag. I haven't put in a lot of CTRs in this context, but I will tell you, I have situations where patients have come in with late dislocations, and it turns out I was smart enough and I actually put in a CTR at the end of the case. And so it means that my instincts are correct. And when I see signs of zonulopathy, I'm not just making it up. It actually is true zonulopathy that manifested with a late lens dislocation. So again, you saw that I put cohesive viscoelastic to fill the chamber and placed it on the cornea. And this is a gonio lens. I want to have a perpendicular view, en-face view, which is code word for I'm able to see equal amount of cornea as well as iris with the angle right in the middle. So I'm placing the Hydrus microstent inside the incision that I made. Go to higher mag. And remember, the tip is like a shovel. You want to angle it a little bit upward into the anterior TM, stab through anterior TM, advance the Hydrus microstent, and once you're in, you want to level out and then continue to advance. withdraw directly backward. Again, with that shovel piece, you're going to push on the notch. You should be able to push it in a little bit more. So again, a really well executed Hydrus. I'm just rotating the eye, making sure I can see the Hydrus along the length of the angle there. Going in with irrigation off, activating irrigation, getting underneath the lens, tilting it, removing all the viscoelastic from within the bag, polishing underneath the rhexis edge, removing all the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this is a patient who had signs of zonulopathy. As I was disassembling the lens, I could sense that there was some weakness as the lens pieces were coming out. The capsular bag felt like it was a little bit floppy. And then definitely as I'm polishing with the polymer tip, you can see the puckering of the posterior capsule, again, validating my suspicion. I place the capsular tension ring again with the injector, and I like using the injector, and I do it all the time, but I use the elaster hook to hook the leading eyelet as the CTR is going in. And as I do that, I'm able to minimize torsional stress on the capsular bag. I feel like this works very well in my hands. And then you saw the Hydrus microstent. At the very end of the case, you can see there's quite a bit of blanching. It seems like there's about 120 degrees of blanching, which is extremely gratifying to see. It tells you that the stent is working. And again, you know, I have a lot of experience placing CTRs. I have a sense that there's weak zonules. And as I've said before, I have been practicing in Dalton for 16 years, and I have now seen some patients coming in with late dislocation. And it turns out when I looked at my op notes, it'll say signs of weak zonules, CTR placed. And it turns out that was a wise decision because now I'm able to lasso suture around the CTR and be able to save the lens implants. And so again, my point is I have a suspicion, and that suspicion has oftentimes manifested in late dislocation. And so I do trust my instincts. And when I see zonulopathy and placing a CTR, not to necessarily prevent worsening zonulopathy, because CTR doesn't do that. It's not for prophylaxis, but to allow you to be able to save the lens in that situation down the road. So I hope this was helpful to you, and I thank you for your attention.